The following program is in no way intended to replace your doctor's advice or treatment program, nor should it be used as a tool for the purpose of self-diagnosis.
I want to welcome you to Your Health, Your Choice. As usual, this program is really designed to give you accurate scientific information about health issues, and then you can make wise choices. I've been saying to many people over the last few weeks, the decisions we make today will determine the stories we tell tomorrow. That was said in a spiritual context, but it's the same with your health. The decisions you make today will determine the stories you tell tomorrow. Over the next few weeks, I'm going to be looking at the American Diabetic Association Standards of Care 2020. Every year, the American Diabetic Association, they publish in January or so, standards of care for diabetes. Now, many of those standards of care are similar to the year before, but every so often there are updates on certain aspects. Over the next few weeks, I'm going to be looking at this. So really the program is about standards of care as published by the American Diabetic Association. Now, I want to really differentiate this from what I did a few weeks ago, which was updates from the recent American Diabetic Association's Congress, which was virtual, of course. It was supposed to be held in Chicago, but it was virtual. And there were lots of interesting trials that I mentioned on the last program, and maybe it became quite scientific, but I did do a case presentation, and some of you fed back to me that it was highly appreciated that I actually did a case of a man who was about 55 years old and had several risk factors for cardiovascular disease. So what we're going to do today is start looking at the standards of care. I want to remind you that these programs are pre-recorded now. Since the COVID-19 situation, we switched to pre-recorded programs, but you can still WhatsApp your questions on 482-4269, 482-4269. Preferably WhatsApp the questions rather than ringing, because that's also the telephone number, my main number for my office, my reception. So 482-4269, it's better that you WhatsApp your question, so it gives me a little bit of time to respond. So we're going to go straight in. I want to show a first slide, slide 10, that gives us some worrying statistics about standards of care. And that standards of care, I think it might be the next slide. Right, yeah, care delivery system. Sorry about that, Josh. I'm trying to give the right slide numbers as we go along. So if you look at this, 33 to 49% of patients still do not meet targets for A1C. And again, I'll explain. By now, most of you know what A1C is, blood pressure or lipids. Only 14% of patients meet targets for A1C, blood pressure, lipids, and non-smoking status. But the progress in cardiovascular risk factor control is slowing. The progress is slowing, and that's surprising. And we need system-level improvements at all levels. So we can probably just come off that slide and just go back through that. So in spite of all the new medications we have on board, all the improvements in healthcare, we're still, and these are figures from America, which of course is a first world country that is supposed to have all the latest interventions where diabetes is concerned. Yet only less than 50% of patients are hitting targets for the A1C. So the A1C is that blood test you do that gives you a 3-month average of your blood sugar. And I always emphasize that your A1C should be done about 2 or 3 times a year. People are not meeting targets for blood pressure. Again, blood pressure in diabetes should be about 140/80. But if you have complications of diabetes like nephropathy, or microalbuminuria or retinopathy, then your blood pressure should probably be a little bit lower, about 130/80. And of course, documenting smoking status is very important for us to do that in our notes, because when you do cardiovascular risk analyses, most of what we call the risk engines contain a component to put in the smoking status. And you can take two patients with the same blood sugar control, same blood pressure control, but if they're a smoker, there's an exponential rise in their risk for cardiovascular disease. And when I say cardiovascular disease, of course, I'm not just talking about heart disease, I'm talking about strokes, TIAs, and peripheral vascular disease. Cardiovascular disease is cardiovascular, so it's a vascular tree. And unfortunately, for some reason, progress in CVD risk factor control is, rather than improving, it's slowing for some reason. And that might be driven by rates of obesity, for example, and sedentary lifestyles. So while we might be controlling people's blood sugar and blood pressure, the other factors might not be as aggressively controlled. And we really need system-level improvements in the overall delivery of diabetes. I'm going to go to slide 17, which has a lot of writing on it, slide 17, and it gives us really a classification, and I want to spend a little bit of time on this, so I'll just read through what I have there. You have type 1 diabetes, which is really an autoimmune beta cell destruction leading to absolute insulin deficiency. You have type 2 diabetes, which is a progressive loss of beta cell function, and you have some secretion of insulin, but there's insulin resistance. Then you have what is called gestational diabetes. This is diabetes diagnosed in the second or third trimester of pregnancy, and it was that patient was not clearly diabetic before gestation or before pregnancy. And then you have certain types of diabetes caused by genetic factors, something called monogenic diabetes syndromes, such as MODY, and diseases of the exocrine pancreas, such as cystic fibrosis and pancreatitis. And you can even have drug or chemical-induced diabetes with glucocorticoids or steroids, HIV, or after organ transplantation with immunosuppressive drugs. Okay, we can just come off that slide. So you have type 1 diabetes. So patients often come in to me and they say, Doc, what type of diabetes do I have? Now, very often we don't do all the blood tests that we may be done in other countries. When a patient comes in, say they're in their 30s or 40s, clearly quite overweight, sedentary lifestyle, the blood sugars might be high, but we basically assume that this is a type 2 diabetic, as opposed to a lean, slim patient who might come in with high blood sugars, and we might, if they're in their 30s or 40s, we may assume they're type 2s, but these are latent onset type 1s occasionally. So there is a role for doing what is called islet cell antibodies or GAD antibodies, and these are antibodies against the beta cells. And if you do that test, as I do in some patients, particularly young patients who are coming in, because again, you might assume a 13 or 14-year-old is a type 1 diabetic. And you know, very often, if a patient comes in with an extremely high blood sugar, 500 or 600, you might, think, oh, they're type 1. But when you do the islet cell antibodies or GAD antibodies or C-peptide levels, you might be quite surprised that that patient is not falling into the spectrum. But bear in mind that there is an evolution of type 1. But if they are type 1 diabetics, especially the antibody test will be positive. And interestingly, we are now looking at patients who might be at risk of getting type 1 diabetes, doing blood testing earlier on, just as we do in pre-diabetes, where type 2 diabetics are concerned, and we can pick up islet cell antibodies or GAD antibodies even before the blood sugars start rising. So that's a new trend that we are looking at in diabetes care. So you have type 1, and again, let me remind you that type 1 diabetics need insulin. There's no place for, at least for now, for oral hypoglycemics or tablets. They need insulin, and if they don't get insulin, so they have absolute insulin deficiency, and if they do not get insulin, the body then can go into a state of what we call ketoacidosis, which is quite a life-threatening condition, and then they have to be hospitalized. Often in type 1s, we see recurrent hospitalizations because some of our teenage or adolescent patients are sometimes not quite compliant with medications, and they skip their insulins, or they might be ill, viral illness, or might be vomiting, and because they're not eating, they think they can omit their insulin, and the body begins to produce what is called ketones, and they go into ketoacidosis, and that can be quite a life-threatening condition. So type 1 diabetes, an absolute insulin deficiency. Type 2 diabetes is where you have a relative insulin deficiency together with what we call insulin resistance, but of course, it has become much more complex, type 2 diabetes. We now talk about something called the ominous octet, and those of you who are techies, who are on the internet, you can Google the ominous octet and see how complex type 2 diabetes is. So while we reduce type 2 diabetes to relative insulin deficiency, so what happens is, leading up to the diagnosis of diabetes, the beta cells are struggling to produce enough insulin, and then you get to a stage, so you actually have what is called hyperinsulinemia. Hyperinsulinemia in the pre-diabetic phase of type 2 diabetes, and that can start up to 5 or 10 years before a patient is diagnosed with diabetes, and then you develop diabetes. At that stage, the beta cells are not producing enough insulin, but you have what is called insulin resistance, and the blood sugars go up. Then you have gestational diabetes. This is where diabetes is diagnosed in pregnancy. Now, if I have time today, I will show you the figures for gestational diabetes. They're quite different from diagnosing diabetes outside of pregnancy. For example, if you do the 75 oral glucose tolerance test between 24 to 28 weeks of pregnancy, and the fasting blood sugar is 93 and above, that's one of the criteria. If the 2-hour value is above 180 and the 1-hour value is above 153, that is diagnosed according to one criteria as gestational diabetes. So let me just very quickly say, gestational diabetes is not someone who has had diabetes coming into pregnancy and then they are found out to be diabetic and we say it's gestational diabetes. So quite a few people, I would suggest, who they are told that they have gestational diabetes may in fact have had overt diabetes coming into pregnancy. And then the last thing on that slide was the pancreas being destroyed by alcohol, excess alcohol intake, by some chemicals, HIV, glucocorticoids inducing almost cushingoid state, causing diabetes. So you have, and then you have the monogenic types of diabetes, which are genetic conditions. And very often, well, most times we're not testing for that in Trinidad, so we don't often see that condition. So, we need to be sure about our diagnosis. How do we diagnose diabetes? And unfortunately, in my mind, we often diagnose diabetes on the basis of a finger prick test. So I quite often have new patients coming into me, and they would say, well, 5 years ago, I went to my healthcare professional and my blood sugar was 250. And then I say, well, was that at a lab or was that in the doctor's office? So while I do finger prick testing routinely on all my patients coming in, I use that just as a guideline, and patients doing their blood sugars at home are just guidelines. But what we need to do is have a proper diagnosis. So I'm just going to bring up, I'm not sure how many more minutes we have before the break, but slide 19. Slide 19 says to avoid misdiagnosis or misdiagnosis or a misdiagnosis, the A1C test should be performed using a method that is certified. Now, the NGSP is an international organization in the US and standardized to the Diabetes Control and Complications Trial. Now, that's quite a mouthful, but the reason for that is that there could be a marked discordance between measured A1C and plasma glucose levels, and this should raise the possibility of an A1C assay interference due to hemoglobin variance. I'm going to explain all of that to you in a minute. So let's just come off that slide. So what we are saying there is that diabetes can be diagnosed with an A1C, the HbA1c. And what is the A1C? It's the glycosylated hemoglobin. And what happens is that the glucose attaches to the red blood cell, and it oxidizes the red blood cell, and the red blood cell has a lifespan of about 120 days. So when we talk about the glycosylated hemoglobin, we are looking at an indirect way of averaging the blood sugar over 3 months. However, if the machines are not standardized, and I'm always careful. Patients often come to me and say, oh, well, I got my A1C done at the doctor's office, so I have a machine at home. That is, there's some machines being sold now. Now, I'm not saying that these machines are not good machines, but you have to ask the question, are these machines standardized against the international DCCT guidelines? That's the Diabetes Complications and Controls Trial, or are the labs internationally recognized or validated? Now, there are a few labs that have attained what is called, I think, the ISO certification in Trinidad. So a lot of the other labs are good labs, they're very good labs, but sometimes I get an A1C, and the A1C might be 5.6%, which is indicating an average blood sugar of 110 to 120. But the patient is telling me that their blood sugars are 200s and 250s, and immediately red lights go off. So as a healthcare professional, I do not take every A1C at face value. In fact, quite often, I've had to ring labs and say, can you repeat this A1C because it's not accurate. The other thing is there's some abnormal hemoglobin types like thalassemia, sickle cell disease, where the A1C may not accurately reflect the 3-month average, because in sickle cell disease, for example, you have a breakdown of red blood cells prematurely, and then if you have a severe anemia, you can also have an abnormal A1C. Okay, a bit complicated, but we have to go to our first break, and we will come back. You're looking at Your Health, Your Choice.
Cloud 9 with your new hosts, Renata and Kimberly Singh. Weekdays at 5 p.m. on AZTN The Voice.
You're watching AZTN The Voice. Connect with ACTN The Voice on Facebook or Instagram at ACTN The Voice. You're watching ACTN The Voice.
Welcome back to Your Health, Your Choice. We're looking at standards of care from the American Diabetic Association 2020 guidelines. This is opposed to the last program I did, which was an update on the recent ADA conference, which was virtual, of course. Unfortunately, we couldn't go to Chicago, which we often look forward to as doctors. It's a great experience to be there in person. But I'm looking at the annual standards of care. I want to remind you again, these are pre-recorded programs now, so you can't call in with your questions. But if you have pressing questions, you can WhatsApp your questions on 482-4269, 482-4269. Some of you are also on my timeline, my Facebook timeline, Claude Khan. I post a lot of the medical information on the timeline, and some of you respond, so you can inbox me. If you send a friend request and I recognize it, you can say you're a patient or something, because I don't accept every friend request that comes. But you can inbox me with your questions as well. And we often, we simultaneously, when this program is being played on Wednesday nights, we also are on Facebook, and I, for the last few programs, I've been actively interacting with people looking on and answering questions as we go on, which hopefully this Wednesday I'll be able to do again. So we were talking about the A1C and having to be a little bit careful. So just to remind you again, if you're a diabetic, please, I hope, you know, if you ever saw me and I asked you when last you had your A1C done, you wouldn't say that you have never heard about this test. The HbA1c is the glycosylated hemoglobin. It's the way the blood sugar interacts with the red blood cells, and it's a 3-month average. So the lifespan of the red blood cell is 3 months. But if you have a medical condition like sickle cell disease, thalassemia, hemolytic anemia, or just anemia, you could have abnormal A1Cs. That's why when an A1C comes in front of me, I often ask the patients, you know, if they're doing home blood sugars, what are their blood sugars like? Because I like to line up the A1C with the home blood sugar readings. I'm going to show slide 21 because this is a slide that very often people ask me about. Now, there's a lot of writing in there, but how do we diagnose diabetes? Well, there are 4 ways, actually. You can diagnose diabetes on the basis of a fasting blood sugar of equal to or greater than 126 after a fast, a caloric intake for at least, no caloric intake for at least 8 hours. So you fast overnight from about 11 p.m. to, say, 8 in the morning, and then you go and have the blood test. Or you could do the glucose tolerance test, which includes the fasting, and then you do the 2-hour post-glucose load, and that should be greater than 200 or 11.1 millimoles per liter if you're in the metric system. Or you can now do the A1C on its own, and if it's equal to or greater than 6.5 or 48 millimoles per mole, which is the new system being used in the UK. Of course, the test should be performed in a lab. And then if a patient has symptoms, excessive thirst, urination, and you do a random blood sugar and it's greater than 200, you can also diagnose diabetes on the basis of that. So let's just come off that slide. That's quite a mouthful. So people ask me, how do you diagnose diabetes? Well, you can do it in 4 ways. So repeat, a fasting blood sugar of equal to or greater than 126 after a fast, no caloric intake for about 8 hours at least. Or you can do the glucose tolerance test, which is the 75-gram glucose load, and then you do the fasting blood sugar before you take the glucose load. You do a 1-hour test, which most labs do, but it's really the 2-hour test we look at if that's greater than 200. Or you can do just the A1C, the HbA1c, at a validated lab. and if that's greater than 6.5, equal to or greater than 6.5. And the last one was a patient who has symptoms, excessive thirst, passing lots of urine, and their blood sugars are above 200. You can diagnose diabetes on the basis of that. But I'll just say on that last one, I'm a little bit cautious about that last diagnosis because, some people will have 5 doubles or 2 bottles of Coca-Cola and then do a blood sugar reading, and it can be extremely high. I would be cautious diagnosing diabetes on that basis. So we want to go on to talking a little bit more now about pre-diabetes, because the thing about pre-diabetes is it is not just an innocent bystander. What do I mean by that? People may think we are medicalizing problems that are not really medical conditions. So pre-hypertension we talk about, or pre-diabetes we are talking about. But the problem, we know that people who are pre-diabetic, if nothing is done, the majority of those patients will go on to develop diabetes. But the good news is if we catch people in the pre-diabetic state, there was a diabetes prevention study and the diabetes prevention program. Both of these programs, scientific papers, research projects, they were done in the 1990s, and they showed definitive evidence that intensive lifestyle, exercise, healthy eating, weight loss can cause a remission or a reversal of the process of progression to type 2 diabetes. So, I have patients coming to me all the time, and they've been diagnosed with diabetes. I had a patient last week, and he said, I'm going to beat this diabetes. I'm not going to take medication for the rest of my life. And, when patients tell me that, I kind of wince a little bit inside, because if that patient has already had diabetes for 5 or 10 years, the beta cells have already exhausted themselves to maybe 60, 70%. And you're then trying to bring a beta cell back into remission, which sometimes can be done. I'm not saying it's impossible, but the job there is extremely difficult. Whereas if you pick up someone who's pre-diabetic, then that is the stage where you can reverse or you can see patients going into remission. And with our big genetic pool of diabetes, and of course, we know we have a literal epidemic of diabetes in this country. We're probably hitting 15% of the population, and then another 15 to 20 or 30% are pre-diabetic. Now this is where setting up of diabetes wellness centers are so important, and I want to congratulate the North Central Regional Health Authority. I saw yesterday on the newspapers. I know it's been going for a while, but there was a big advert about the Diabetes Wellness Center at Mount Hope Hospital, which actually I went in and had a look at about a year ago. And it's a very, very good setup. It's a multidisciplinary team. It's very much like the diabetic centers I worked in the UK. So I want to congratulate the staff there and the North Central Regional Health Authority for having the vision to set up this wellness center. And I would suggest that the other health authorities need to have a look at this model and begin to try and replicate this in other areas. So I'm going to bring up, I think it's slide 26, on prediabetes and type 2 diabetes. That's 24, 20, 26, 20, 28, I think. I think it's going to be 28. Okay. Let's go back one. Sorry, Josh. Let's just go back to one slide. Yeah. So prediabetes and type 2 diabetes. In fact, I think I have my numbering of my slides wrong. So we have to go back one more to slide 25. Slide 25. So can I go back one more? And then I don't know how I got this wrong. In fact, it's slide 21 I think I wanted. Let's try slide 21. and 21, 22. 22. Okay, let's. So screening for type 1 diabetes, islet cell antibodies recommended. I've already talked about this. Let's just go to the next slide. I think I'm getting my slides mixed up. All right. So yeah. Sorry about this, Josh. I'm working, Josh, hard in the background today. So pre-diabetes and type 2 diabetes. So this is what we are saying. Screening for pre-diabetes and type 2 diabetes with an informal assessment of risk factors or validated tools should be considered in asymptomatic adults. So I'm going to come to that, what I mean by that in a minute. So testing for pre-diabetes or type 2 diabetes, this is in asymptomatic people, should be considered in adults of any age who are overweight or obese. So if their BMIs are above 25, or if they are of Indian background, a BMI of above 23, and who have one or more additional risk factors for diabetes. And I'll explain what I mean by that. So testing for prediabetes or type 2 diabetes should be considered in women planning pregnancy who are overweight or obese. Let me just go to the next slide and finish off this discussion. So for all people, for prediabetes, should begin at 45 years old. And that's not being done in Trinidad. If the tests are normal, repeat testing should be carried out at 3-year intervals. And to test for prediabetes, you do a fasting blood sugar and then a 2-hour test. And in patients with prediabetes or type 2 diabetes, identify and treat other cardiovascular risk factors. Now, that's quite a mouthful that we have given there. So I'll just come off that slide. I think that was slide 24. So let me just summarize what I've said there. So who are we going to look at for people who we want to screen for prediabetes? So this is where we get into preventative medicine, where we are trying to pick up people in a pre-disease state, if you want to say it. And we do that for other conditions. For example, cervical cancer. That's why pap smears are recommended for women who are sexually active, I think above 21 or 23 years old, every 3 years, because you can pick up cells that are precancerous, or you can pick up the human papilloma virus, which if treated, HPV virus is one of the precursors for cervical cancer. So there is a precedent for screening people who can develop a medical condition and trying to identify those who are at risk. Similar with prediabetes. So we are saying if people are overweight with a BMI above 25, so your body mass index is your weight in meters over your height squared, so your weight in kilograms over your height squared. And if that's above 25, and you have one other risk factor for cardiovascular disease, it might be hypertension, it might be hyperlipidemia, it might be a family history, then you should be screened. Now, one of the things we looked at is there's a difference in the ethnicity. So if your BMI is above 23, which is quite, you're talking about people who are not very overweight, but you have someone who with a BMI of above 23, but they have other risk factors for cardiovascular disease. You also want to screen. That's in the East Indian population here in Trinidad, but in the UK or the US, people from the subcontinent, from the Indian subcontinent. You want to screen those people because a lot of them may develop or may be shown to be pre-diabetic. And if you pick up people who are pre-diabetic, then you want to treat all the additional risk factors for cardiovascular disease. So if they are hypertensive, you want to treat their hypertension aggressively. If they have high cholesterol, you want to treat that. If they are overweight, you want to intervene with low-carb diet, not ketogenic, but low-carb diet and exercise. I'm going to come back now to slide 26. I know we showed this, and it wasn't the slide I was ready for. But this is slide 26 now. Again, there's a lot of writing here. The criteria for testing for diabetes or prediabetes in asymptomatic adults. So these are patients that have no symptoms at all. They may come into you as a family doctor or as a healthcare professional. And who are those that we should be testing if they meet the weight criteria? Well, if they have a first-degree relative with diabetes, a mother, father, brother, or sister, the high-risk race, Afro-Americans, Latinos, Native Americans, Asian Americans, history of cardiovascular disease, so if they have had a stroke, heart attack, if they have hypertension, as I said. Now, the cholesterol one I'm going to come back to, but if their HDL cholesterol is less than 35 or their triglycerides are above 250, or women with polycystic ovaries, physical inactivity, all those conditions, or women who were diagnosed with gestational diabetes should have lifelong testing for diabetes every 3 years, and all other patients above 45 years. So I'm going to come off that slide. That's a mouthful that I've just given you, but I just want to recap some flags here that we should be looking at. So what am I saying? The American Diabetic Association is saying people who meet the BMI criteria above 25 generally in the general population, but if you are in one of the ethnic groups that I mentioned, and here in Trinidad, the Indo-Caribbean population, and your BMI is above 23, your body mass index is above 23, and you have a first-degree relative with diabetes, so you have a father, mother, brother, or sister with diabetes, you should be screened with an oral glucose tolerance test. And I'll tell you why the oral glucose tolerance test. Or if you have hypertension, if your blood pressure is persistently above 140/90, your lipid profile, very important, and I see this a lot in patients coming in. They are, their HDLs are low, the good cholesterol is low, below 35, but their triglycerides are above 250. And that's a marker for something that's going on in the metabolism that is churning out the very toxic LDL particles. So the LDL values may not be bad, but they may be highly dense LDL particles, especially if the triglycerides are high. Now, in the US and other countries, they're doing more advanced lipid testing. They're testing for something called ApoB, which is a marker for toxic cholesterol particles, more dense cholesterol particles. So there are sub-analyses that can be done, and I think 1 or 2 labs in Trinidad were doing it. I'm not sure if they're still doing it. So someone with a low HDL and high triglyceride should be screened. Women with polycystic ovaries or polycystic ovarian syndrome. Now, let me just be quick to say, not everyone with polycystic ovaries will have polycystic ovarian syndrome. So I see this all the time. A lot of women are told that they have polycystic ovaries and therefore they're going to be infertile. I just want to debunk that a little bit. Polycystic ovaries do not always equal polycystic ovarian syndrome. You need to have the hormonal profile, raised FSH, or in the FSH-LH ratio should be abnormal, or prolactin levels might be abnormal. Or if you do even testosterone levels in a female with polycystic ovaries, it might be slightly raised, resulting in excessive hair growth, etc. So polycystic ovarian syndrome, physical inactivity. And the other big category that we are missing is women who have had gestational diabetes. So, I want you to remember this. If you had gestational diabetes, that is diabetes in pregnancy, you then had the baby and you were told the diabetes has cleared up, nothing to worry about. That's a mistake, because over 50% of people with gestational diabetes, a few years down the line, they go on to develop full-blown type 2 diabetes. So if you have had gestational diabetes, every 3 years or so, you should have a glucose tolerance test to make sure that you're not pre-diabetic or you're not going back into diabetes. And then, of course, all patients who are above 45 years old should start having every 3 to 4 years glucose tolerance test. And before we go to our break, why do I emphasize the glucose tolerance test? Because if you just do a fasting blood sugar, very often the fasting blood sugar will be absolutely normal. The first blood sugar reading that becomes abnormal is the 2-hour after meal or the 2-hour post-glucose tolerance test. That's why we emphasize not just doing a fasting blood sugar, but doing the glucose tolerance test and the 2-hour value. Okay, we're going to have to go to our final break, and we will return with Your Health, Your Choice.
Exclusively on ACTN The Voice. This is Messenger TV. Join us as John and Lisa Bevere equip and empower generations of Christians, both young and old, developing uncompromising followers of Christ who transform our world. Starting on Mondays at 8 a.m. with repeats to fit any schedule. Tune in, log in, or click on the Word like never before. Stay tuned for a new experience from the Word of God with Messenger TV, exclusively on ACTN The Voice.
You're watching ACTN, The Voice. Connect with ACTN The Voice on Facebook or Instagram at ACTN The Voice. You're watching ACTN The Voice.
Welcome back to Your Health, Your Choice. We are looking tonight at the standards of care that the American Diabetic Association puts out every year. So 2020, they've put out their annual guidelines. This is as opposed to the program I did last time, which was looking at the annual diabetic conference, which was virtual this year. And I mentioned a lot of late-breaking trial data on the last program. So when in the last section of the program tonight, and I want to remind you that we are not live. These programs are going to be still pre-recorded for the foreseeable future. So if you have questions, you can WhatsApp your questions on 482-4269, 482-4269, or you can go on our website, www.anaposiscommunity.com, and there's a medical page. It's a kind of holistic site, but there's a medical page. Or if you're on my Facebook timeline, you can inbox me if you are a friend, I guess. I think that's how it works. And if you inbox me privately, I try to answer your questions. So I try to give you as much access as possible, because for me, healthcare is more than just coming to an office to see a doctor. You need information. So I'm going to spend a few more minutes on prediabetes, and probably for the next few minutes, for the rest of this program, I'm going to bring up slide 28. Slide 28 is the criteria for the diagnosis. Now, this is a criteria for the diagnosis of prediabetes. So again, you can diagnose, as opposed to diabetes, which we said you had 4 criteria, 4 ways of diagnosing type 2 diabetes. Prediabetes, you have 3 ways: of fasting blood sugar of between 100 to 125. Fasting, again, you have to be fasting for about 8 hours overnight, preferably no caloric intake. Or you can do the 2-hour glucose tolerance test, and if that value is between 140 to 199, ignore the millimoles figures, those are the UK figures, 140 to 199. Or if you do, the A1C, the HbA1C of between 5.7 to 6.4, then you are labeled as pre-diabetic. So we can just come off that slide 28. So there are basically three ways. So, a patient comes into me, they do, they've heard about prediabetes. Very often patients say, Doc, I heard you talking about prediabetes. I have a family history, or I have some other risk factor that we talked about. I want to do this. I want to do a test. So invariably, I would send them, not just for the fasting blood sugar, I would do the A1C plus the glucose tolerance test. So I have two values to look at. So if that patient, the question always arises then, if that patient comes back with a fasting blood sugar, say of 115, if the fasting is maybe around 100, 101, technically they're in the pre-diabetic range. Or if the A1C is around 5.7, 5.8, just in the pre-diabetic range. Or if the 2-hour value is about 150, 145, 150, technically, yes, in the pre-diabetic range. But unless there are compelling reasons, a very, very strong family history, and I do see, really, really strong family histories of diabetes where father, mother, brothers, sisters, literally everyone has diabetes. I'm much more likely to start treatment at that stage with medication, not just lifestyle. But if that patient is just within the pre-diabetic guidelines, I'm going to really push, and especially if the patient has a sedentary lifestyle and is slightly overweight and is clearly eating badly, I'm going to spend quite a bit of time with that patient going over the basics of food portions. I'm not a dietitian, so I may still refer them to a nutritionist or a dietitian, but I emphasize food portion control, cutting back on the carbs, especially the high glycemic index. Glycemic index, Google that. All of you who are looking at me and you're into technology, you just enter glycemic index on Google search or one of the other search engines, and you come up with a list of foods that are high GI and low GI. So what you want to move towards is the low GI foods, because the low GI foods are absorbed more slowly, and therefore it's putting less pressure on your pancreas. So it's basically high fiber foods, moving away from the white flour and white rice to more whole wheat or the multigrain whole wheat bread. Ground provision, yam, dasheen, sweet potatoes, better than the white rice and white flour. But still it should be about a quarter of the plate. And then you need to fill up the plate with vegetables and salad, not just tomatoes, cucumbers, etc., but cooked vegetables, bhaji and pumpkin and buri and all these good, wonderful cooked carrots, wonderful vegetables that we can have. Fill up the plate with that, and then the white meat, the lean cuts of meat, better. So I would emphasize in that patient lifestyle, and I'll try to push that patient to start exercising. And in many ways, lifestyle is the most difficult thing to change. And I often say a good or bad habit is something that you repeat for about 30 days. And if you repeat it long enough, it becomes part of your almost reflex pattern of living. So waxing a bit philosophical now, for me, getting up in the morning around 5:45, taking my cup of coffee, going onto my back bench in my back garden, taking my, my phone is on my Bible is on my phone now. Starting to read and meditate and sending out Bible. It's part of my life. If I don't do it, something's missing. Now even exercise, I can maybe boast a little bit, has become part of my routine for five times a week at least. So you can do it. You can do it. But who are those patients that I would more likely put on drugs? And I know there's all this about big pharma, and as doctors, we want to put people on statins, we want to put people on blood pressure tablets, and people often ask me, so doc, what are the side effects of these tablets? I've heard these tablets damage my kidneys, damage my liver. Listen. There's so much fake medicine out there that you need to be careful. You need to go on reputable sites. Check out WebMD. Check out some reputable sites. Go on to the American Diabetic Association and Diabetes UK. And the fact is, what damages the kidney and the heart, and will cause a stroke and bleeding at the back of the eyes and early damage to the kidneys and to the feet, is poor blood sugar, blood pressure, cholesterol control. And therefore, so if I have a patient who's pre-diabetic with a fasting blood sugar of about 120, a 2-hour value of about 180, 190, an A1C of about 6.2, that patient is very much on their way to becoming diabetic. And especially if they have a family history, are much more likely to put that patient on basic medication. And glucophage or metformin has been shown to act against insulin resistance, so it allows the pancreas to work more effectively, and then might reverse some of the progression. Or I sometimes advise on some natural supplements. There's something called fenugreek or cinnamon. Yes, I actually do suggest some of my patients using some of those products, because there's some emerging evidence that those products can help with insulin utilization. I just want to probably bring up the last slide, which I think is slide 29. Slide 29. Josh, can I just, yeah, that's it. So this is an at-risk form that can be done. Now, you can't see this very clearly, but there are about 7 questions, and if you score 5 or higher, you are at a higher risk of getting diabetes. So how old are you? If you're less than 40, you score 0. If you're 40 to 49, you have 1 point. 50 to 59, 2 points. 60 years and older, 3 points. Are you a man or woman? Well, unfortunately, if you're a male, you score 1. If you're female, 0. So men seem to be more at risk of diabetes before women hit the menopause. If you're a woman, have you ever been diagnosed with gestational diabetes? If yes, you score 1. Thank you, Josh, for enlarging that. Wonderful. And some of you should take a photo of this. Those of you who are looking on, or if you send me a request, I can send you this by WhatsApp, because as many of you who are not diabetic who can do this, if you have a mother, father, sister, brother, or a sibling with diabetes, you score 1 point. Have you ever been diagnosed with high blood pressure? You score 1 point. Are you physically active? No? Well, you score 1 point. Yes? Well, you're doing well. And what is your weight category? So that's where we look at your BMI. So if you want to take a photo of that with your phones, you can do that, because you can do the scoring at home. So I'll just come off that slide now. This is a wonderful, and there are other analyses that can be done. There's a Swedish scoring system as well. But this, basically, we're looking at 7 factors. So you're looking at how old you are. You're looking at male, female. You're looking at whether you've been diagnosed with gestational diabetes, whether you have a mother, father, sibling with diabetes. Have you been diagnosed with high blood pressure? Are you physically active? What is your weight category? Now, the weight category is something that you would have to look at in the table that's on your right-hand side. So, for example, if you're 5'7" and you are between 159 to 190, you score 1 point. So I might actually score 1 point, because although I lost some weight after my medical diagnosis, colon cancer, some of you know I had 2 years ago, but I'm cancer-free. I am now about 170, but I was about 185 at one stage. But if you are 191 to 254, you score 2 points. And if you are greater than 260 or 255, you score 3 points. Well, we only have about 3 minutes left. So if those of you who would like that, I would try, if you WhatsApp us on 4824269, I can try and send that to you. Or I may very well try and put this on Facebook on my timeline. So those of you who want to do a risk analysis of how high your risk is of diabetes, You can do this, or you can do this for your family members, because, you know, a lot of people stick their heads in the sand and they're in denial, and they don't want to touch the issue of whether they're at risk of diabetes or not. Can I just say, saying that you are at risk of a medical problem is not saying that you're going to get it. It's just saying that, look, I can take steps now to try and to do some preventative therapy. So over the next few weeks, I'm going to continue this slide set, because there are lots of slides that I need to cover. But what I've tried to do today is some basics, looking at diabetes, diagnosis, the types of diabetes, and then we launched into those who are at risk of getting diabetes, and then we have spent some time looking at pre-diabetes and ways in which you can turn the clock back. Once again, the telephone number is 482-4269 for your questions or medical appointments, or wanting to find out more about the Anaposis Chapel. As you know, I'm also a pastor, so I now put on my pastoral hat. You know, I started a new series about a week or two ago at our church called There's a Reason. There's a Reason. And yesterday I shared on finding out your why, W-H-Y. What is the reason for your life? But the week before, we talked about pain, the perspective of pain. Now, we're living still in a pandemic, and I was looking at the news conference just before coming here, and there are thousands of our citizens who are stranded abroad and are in painful, struggling situations. And I understand why the Minister of Health is saying that we still need to keep our borders closed. But whatever the painful situations you are facing, when we think about Peter, the great Peter, Jesus said to him that Satan wanted to sift him as wheat, but he would pray for him. And Peter must have said, well, Jesus, take away these painful episodes rather than just pray for me. But Peter went through various painful episodes, denying Christ and falling asleep in the Garden of Gethsemane. Yet on the day of Pentecost, he preached one of the most majestic sermons ever. Can I say, sometimes when you look at pain, purpose is often packaged in your painful episodes in your life. And I want to repeat that as I end. Very often, pain is packaged with purpose. And the more painful the episode, maybe, just maybe, God has an even greater purpose for your life than you ever thought. Thank you for joining us tonight on Your Health, Your Choice. This program will be played on Wednesday nights at 8 and then on Thursdays at 1 p.m. And we come back with another program in 2 weeks' time. I am Dr. Claude Khan.